everybody. Good morning. We're happy to see so many of you here already to begin our day. My name is Nikita Boston Fisher. I'm the Associate Director for the Laidley Center for Business Ethics. And it is my pleasure to call you all to attention and introduce our wonderful Dean, Yolan Chan of the Desautels Faculty of Management, to welcome us and give us today's opening remarks. Dean Chan.
Thank you, Nikita, and good morning, everyone. Bienvenue. Welcome. It is indeed wonderful to see such a great turnout for the Laidley Center Inaugural Business Ethics Conference. Before I continue, let us pause. We must acknowledge that this great university sits on land that has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. It's important to acknowledge and thank the diverse Indigenous peoples whose footsteps have marked the land on which we now work and play and live. So, under the theme Healthcare, Ethical Management for Systemic Challenges, this inaugural event helps McGill and Desautels mark National Health Ethics Week, which comes to a close tomorrow. Today's conference takes place in the context of the extraordinary ethical challenges the healthcare industry faces, particularly while also facing a global public health crisis, severely constrained resources, social unrest, war, and obstacles to access. I cannot think of a more timely healthcare topic to address. As McGill University's central hub, supporting ethical decision-making in business through teaching, academic research, and community engagement, the Laidley Center is profoundly well-placed to guide today's discussions. Since its inception last year, the Laidley Center has organized a variety of important events, including speaker series, discussions on AI ethics in business, cross-faculty ethics research events, the McGill Desautels Accounting Ethics Case Competition, and the launch of the Business Ethics Ambassadors Program. A lot has been achieved already. With respect to today's event, I must thank a number of people for bringing us here together at this faculty club to engage in important reflection and discussion. My thanks go to Director Lindsay Holmgren, Associate Director, you just heard from, Nikita Boston Fisher, Outreach Coordinator, Joelle Moses, and all those who've contributed to organizing this conference and who have volunteered their time. I also wish to thank the panelists you'll hear from today. They'll be sharing valuable experience, expertise, and insights. And I want to thank you all, the audience. You've joined us, and we look forward to hearing from you also. It is important and fantastic to see the variety of schools, faculties, programs, hospitals, and healthcare institutions in attendance today. Of course, none of this would have been at all possible without the vision and the generosity of BCom alumnus and Desautels International Advisory and Advancement Board member, Mr. David Laidley. Merci, David. I hope you're proud proud of how far the center has come since your generous donation and its launch almost a year ago to this day. It was launched on November 14th, 2022. I have the opportunity to thank one other person, Mr. Lester Fernandez, also a dedicated alumnus and visionary donor. It is my great pleasure to make visible, perhaps for the first time, something significant. And you'll see the impact of this in the years to come. With Mr. Fernandez's support, I'm pleased to say we're establishing the Lester J. Fernandez Chair in Business Ethics. Thank you. This chair is going to equip us to enhance our academic programs in ethics, programs that will allow students to champion workplace ethics and ethics in a number of settings. It will foster collaborations with a diverse network of educational and business institutions and promote general excellence in research in ethics using a multidisciplinary approach. Merci. We look forward to see the center and the chair serve as tools to engage you, the broader community, to facilitate dialogue, to share best practice, and to enrich the ethical landscape of not just business, not just healthcare. In today's days, we have to go even beyond that, society at large. So thank you both, and thank you all for helping to prepare ethical leaders to face today's challenges, which are significant, and the challenges we can only begin to think of, the challenges of the future, which we know will be daunting. So, with no further ado, it is my great pleasure to officially start the day by inviting to the floor Robert Nason, Associate Professor of Strategy and Organization, who's chairing our first panel on ethics and innovation in healthcare. So thank you all. Please enjoy this thought-provoking and important day. It is the first of many Laidley Ethics conferences. Merci.
Thank you, Dean Chan. Thank you, everyone. While my panelists get started, I'm happy to kick things off. And I think starting with talking about innovation is a important and kind of apropos way to kick things off. Without innovation, it's going to be difficult to address systemic challenges. This is something that's critical and inherent to it. And we're going to talk about today the tremendous need, and Dean Chan already alluded to, the need for innovation in healthcare to address these systemic challenges. But with this comes much challenge as well. And I think it's fantastic that we're integrating ethics into this discussion around innovation. There's much talk in many panels on innovation, too few that integrate and explicitly talk about ethics. And I think we've seen this in our society today with some high-profile innovations and entrepreneurs that have had humongous ethical failures that's led to business collapse and a lot of tragedy along the way as well. And this focus on innovation, it's something that's risky, it's something that involves uncertainty and the potential for bad outcomes, and so it's particularly important that we're conscientious of thinking about its role, not just in developing new apps that users might use, but when we're thinking about patient outcomes and health and lives at stake. And so this warrants kind of a deeper dive. And I'm privileged, and we all have the pleasure to have a distinguished panel to help us put in the work to think through some of these challenging issues today. So the structures, I'm going to pass it off to one at a time. I'll introduce them each before they talk. They'll have about 10 minutes to share some opening remarks, and then we'll have plenty of time for Q&A at the end. So first up is Laurette Dubé, who's a professor of marketing and the James McGill Chair of Consumer and Lifestyle Psychology and Marketing. She's also the chair and scientific director for the McGill Center of the Convergence of Health and Economics. So, Laurette.
Thank you. I can speak from here?
Yes,
okay.
please, yeah.
It's a great pleasure to be here this morning, and thanks to the organizer. My opening comment will relate to the systemic challenge in the healthcare industry. Dean have been mentioning, they are daunting, and the real-world solution, whether it's entrepreneurial or other, clearly have thus far not having sufficient scope, and that if we recognize that the ever-increasing healthcare costs are often cited as the most significant financial threat to government worldwide. The Economist has a great piece this week talking about the world economy is defying gravity that cannot last, and they were blaming it, correctly so, on higher for longer interest rate and explaining a lot of micro and macroeconomics. But I would claim that healthcare costs is not far behind, and that we really, as a world, not just in Canada, get to bring another level of action. Not only do we have, and why so, not only do we have a growing and aging population that typically needs more care as their life course advances, but also the modern life collateral such that care is needed earlier along the life course, with the prevalence, healthcare costs, and mortality from cardiovascular and diabetes and other NCD in the 35 to 64 group booming over the last couple of decades. The Washington Post published a report a couple of weeks ago of a one-year exploration to kind of conclude the following. Sadly, Western countries like Canada and USA are failing at a fundamental mission and ethic aspiration at the systemic level, keeping population alive. So that is an important, when we think of ethical challenge and innovation challenge and technology challenge, we have the individual, we have the system, we have the professional, and that's really why it is important to start embracing some of this complexity. Some of the stats that were reported there was, for instance, life expectancy, long regarded as the single expression of whether we succeed or not as species, peaked in 2014 at 78.9 years, then drifted downward even before the pandemics. In 2021, according to CDC, life expectancy reached the bottom at 76.4. And our stats in Canada are slightly different, but very, very much similar to when we think of ethics as doing what is good for the person, what is good for the system, and what is good for the actors in the system is a key part of what I would like to put on the table as we open this discussion. Further, at provincial, national, and global level, the phenomenon that we are talking are further accelerated by the general polarization that we see around the world those days on economic, political, or racial divide. So the distinction between the have and have not is not just financial or house anymore. It is really in terms of those key human signal of life and death. And it's extremely an important piece in thinking about ethic management in the context of systemic challenge. It's not just the healthcare sector. We have this kind of do no harm umbrella that bring everyone together, but we do need to fully acknowledge the diversity and the complexity of addressing those ethics framework in a way that create at any point in the system ethic, behavior, and so on, but also create system-level outcome in some way. And let's be realists, it means that sometimes the individual level Hippocratic type of framework and the system level, there are conciliation to be done when we look at moving forward real-world action. To accelerate the speed and scope, and the other piece also that is important is that the effort that are done in innovation, entrepreneurship, and so on, to bring technological solution or to bring also more inclusive and responsible innovation are moving in the right direction. But the point that I would like to make is that if it remains within healthcare, we are not addressing the cause of the cause and the social, quote unquote, the social determinant, which are our everyday life as human and also everyday life for the organization and actor in all the non-health sector. So that is why, and it's good to see Dick here, I think we started this convergence approach 20 years ago, and that is really with the idea to what extent can we bring this convergence by design that bring together research within and across discipline, intervention within and across domain, in a manner that create more synergy in all of the above in a way that is tractable and measurable and so on and so forth. And we have, and I will maybe end by giving an example of something that the whole network of this convergence by design I've been working on here in Montreal, for instance, in the domain of healthcare. There is a project with the Eva Martin Center for Social Justice and Aging and with the CE Centre West, we will have Dr. Goldberg here, for working to see to what extent we can bring AI and digital technology and so on in helping the community organization to have a good understanding of where are the resources around where a person lives and so on. And this is called Click Social, and it is developed with use cases that are how can this support not just the community organization that are still very much outside of the healthcare, but also three entry points, the CLSA, the Groupe de Médecins de Famille, whatever we say in English, family care practice, but also, and that is some interesting development, still the Centre West has been putting together last year this primary care access, the gap, where if you are between access to your regular primary care, you call there, and there is so the ecosystem that we are creating on the health side is bringing innovation, technology, and so on, but within the context of how can this be designed for and integrated with the real-world resources that are out there. And similar exercise is not just exercise, it's a real project that is all of those are part research, part investment by the partner, and so on. The other line of work, which is led by my colleague Sarah Ahmed from the Faculty of Medicine here, is this project for articulating a patient portal platform that the patient that gets out of brain injury level of care go back home, and to what extent can there be a key bridge between the patient, that I would like to call the person, and the actual more formal healthcare system. So that gives an example of how we can bring this, the best of what we do now on the more mainstream medical technology and so on, but embed this into the real world, that is the real world of healthcare, but also the real world of society and the family and so on. So I will end here. That should be enough.
Thank you. Thank you so much, Laurette. So that lays a good foundation. And next we have Dr. Alan Forster, who we're lucky to have join us just very recently, and now is coming in as the Director of Innovation, Transformation, and Clinical Performance at the McGill University Health Center. So welcome, Alan.
Thank you, Robert, and thank you, everyone from the organizing committee to invite me, and it worked out well from a timing point of view that this was also my first week living here in Montreal. So it's a pleasure to speak to this topic of innovation and the ethical challenges. I'll speak to this from the perspective of someone who's been involved in innovation throughout his career. Obviously, I'm not an ethicist, but I can see some of the challenges that come through that face us as we move it forward. And for me, innovation are technologies, new technologies that are being brought in and being implemented that then ultimately bring value to the society, whether that be directly to a patient or to the population, or through other value, through other benefits by reducing costs. And so it's clear to me that innovation is really needed right now. We have, as was just said, we have costs that are going to consume and perhaps lead to very significant negative impacts on our public services and public accounts. We also have a health service actually that's crumbling right now, and you could say that it's Quebec, but it's actually everywhere. It's the same problems. And it's not just in Canada where it's publicly funded largely, but it's pretty much everywhere. There's major struggles, and so unless we think of new ways to do things, and that includes the delivery of care, but also how we pay and govern care, and how we engage public and people to look, as was mentioned, to look after their own health, I think we're going to continue down this path, and it won't end well. And that in and of itself will promote change. That in and of itself will promote change. So I see a lot of companies and a lot of products come forward with ideas, and I speak to a lot of people people who work in institutions who have ideas. And where I'd say we're really good is that we're good at getting those ideas to a prototype, to an idea that where we can actually have a prototype that demonstrates potential. Where we struggle is we struggle in getting that prototype to a position where it's demonstrating it shows value, and then we struggle even more getting that prototype to a product that's being used in creating that value proposition. And that's again not just a problem of Canada. It's a global issue. Now, some technologies like pharmaceutical products, they are better than some other types of products. Like they get to market, there's a pathway. I would still say we struggle with pharmaceutical products in actually ensuring value is being created. We all know that many drugs are prescribed, people don't take them, or they cause harm, or that they don't actually create the benefits that are expected. But at least there's a pathway to getting there, and we've seen some fantastic benefits from pharmaceutical products, from medical devices. Where we're lagging right now is on the digital front. And in healthcare, I think a lot has been spoken about how digital technologies have not been able to we've not been able to get the benefits from digital technologies in healthcare that we have in other fields. And so the question of what are some of those challenges. And I think it lies at that part of getting products to be adopted and used. It's not so much at that early phase of getting prototypes. The prototypes come. It's getting them used. And so I'll describe some of the challenges as I see them and as I've experienced them. And I think others have experienced the same. And I know Lawrence is going to speak a little bit about some of these as well, so I don't want to speak too much about I won't go into too much detail. The first is around conflicts of interest. Some of this is perceived and some of it's real. The idea that a company would be coming forward, often and working in close collaboration with healthcare providers to help generate a product that ultimately there has to be revenue in order for that product to continue to be available. So the company is motivated to push its product harder than perhaps it's ready to be pushed. But at the same token, if it isn't pushed, the product will no longer exist because the company will fade away into nothingness. But that means that they're motivated to make their product successful, and they're working with people whose motivation is just there for the patient or for the system. And that inherently creates a conflict of interest that is very difficult to overcome. It diminishes trust amongst people working in the environment. And that lack of trust then diminishes the type of collaboration that's required in order for us to actually advance knowledge of how that technology is going to play out. The second challenge I'll lay out is consent. Patients come into our institutions and get the care they get. We are now coming in with new products that may have been tested, and the amount of testing may somewhat be limited. Some of it may be quite well tested, but we have to bring these are big system changes, and individual patients are not really in a position to consent for this in a true way. And so we need to think of methods by which we can have a dialogue with society and with individual patients that recognize that these changes are going to be happening, but in a context where there really aren't options. You can't randomize people in these situations because if you bring in a new computer system, and that's the way it is. We don't really know how it's going to work out. We think it's going to work out well. It's only going to work well after we work with it and get it to use. So how do you engage in where you allow people to have autonomy in that situation? It's very difficult. The third are the risks and benefits in the third topic is risks and benefits in a publicly funded system. Companies, and then through the companies, investors are going at risk for themselves personally and for their product. The hospitals or health system, they're going at risk to buy these products or to experiment with these products. If it works really well, everyone wins because the hospital gets value and the company gets profits. If it goes badly, as was mentioned, the company does badly, it doesn't exist anymore, the hospital, patients are harmed, its reputation is harmed, its bottom line is harmed. In that environment, it's very difficult to create investment vehicles for companies and hospitals to thrive because, as was mentioned, there is risk involved. And hospitals, the way hospitals and health systems are funded, there really isn't often a lot of capital around to invest to make these kinds of investments. The way most hospitals are funded, there really is operating dollars allocated through a budget process that doesn't enable discretion in terms of things that you might want to experiment in. And the downsides are very large if you don't spend the money the way you're supposed to. So the risk benefit in a publicly funded system in which private sector is coming in with new technologies developed makes it very difficult to move forward. And then the last concept that I'll bring up is around sharing data. And you know, obviously, if you're working on a product, you want to know as much as you can about that product and whether it's working and whether it's not working. If you're not allowed to get data out of a hospital because of privacy rules or technical capabilities that's showing how well the product could work and how well it is working and where you might improve it, it becomes almost impossible. And of course, this isn't a conference on data and privacy, but clearly there are challenges there. And so those are 4 sort of major barriers and system challenges and they're all rooted in ethical concerns. They're all rooted in ethical concerns that limit our ability to scale prototypes up to a viable technology. I won't speak much about how to overcome them, other than to say that there are, I think, ways. It does take an openness and an open dialogue like we're having today with multiple inputs. My sense is that governance of healthcare needs to include this capacity, and we haven't systematically advanced that. My also feeling is that there are frameworks by which we can balance the risks and we can create decision making so that the conflicts can be put forward and declared and evaluated and ensured that they're managed appropriately. And then often innovation stumbles because we don't have the rules. And so clarity of process and procedural factors in which there is oversight and governance can overcome many of the challenges I discussed. And then the last part, and I will save this mainly for the discussion, for the data piece, there are some new technologies. Synthetic data is one, where we can actually, using artificial intelligence, create fake data out of real data, which maintains the statistical properties and learning opportunities of the real data, but do not pose the challenge with the privacy. And that becomes now a massive opportunity for society to really understand what the opportunities may be, as well as whether things are working, because we can rely on the synthetic data as opposed to having this risk over personal information being shared inappropriately. With that, I'll stop, and I hope I haven't spoken too much that's going to steal your thunder, others. But anyway, I'm hoping the discussion will be able to get a bit more details into this. Thank you.
Great, thank you so much, Alan. Next, we have someone who is living some of these ethical challenges and dilemmas every day as an entrepreneur, and will share a bit about her experience with that. So, Negan Ashuri is the co-founder and CTO of Fem Therapeutics, which is a Canadian-based medical technology company harnessing the power of 3D printing and artificial intelligence to improve treatment outcomes of women's health. So, welcome, Negan.
Thank you so much. Hi, everybody. Pleasure to be here with you all. So I'm going to be speaking a little bit from a lens of a company that has been existed for about 2.5 years, and has raised basically 2.5 million so far, and is raising a little more money as well. So I'm going to be talking first about how what are the challenges that we have faced practically when growing our businesses, and what we've actually foresee that happens in the future. So first thing that I wanted to mention is that it's not really easy to stay and remain ethical, especially when you're a small company that needs to grow. Also with all the challenges that comes in, we know that small companies are infrastructural for all these innovations and new things. Big companies usually don't have the time or do not really want to get into the niche, as we say, small problems that the patient has. So it's really important to look at the small companies and how they can bring to the table in terms of innovation. And then basically that's why all the medical device companies, their exit strategy and vision is to basically build a product and then sell it to bigger players, and then move on to the next product and go on. But here I would like to actually first emphasize on the approach of institutions or administrations such as FDA has, their approach regarding these small companies versus the big ones. There is a documentary actually on Netflix that is called Bleeding Edge, which actually emphasize the problems that patients go through while having insufficient tests that has been done on the products that are offered to them. Some of the biggest players in the market, they are just fast tracking their products to get into the market without actually having the patient needs on the front line. This documentary, most specifically, are actually emphasizing two of the products that they are working on. They've been actually showing was, for example, eShare, which is a contraceptive device that is implanted in the uterus, and then also a transvaginal mesh, which is also implanted in the body, but lots of allergic reactions or also uncomfortableness, tissue growing towards those implants, which makes doctors, it makes it impossible for doctors to actually remove them. So doctors are actually trained on inserting them, but they're not trained to remove them. Because that's actually horrifying. But because of insufficient testings that hasn't been actually done in that space, FDA would let these products to get into the market, and then it poses all the pressure on the patient side to go through different complications, and then it shows how a patient had to go through multiple surgeries, about 20 surgeries, just to get rid of a complication of the first surgery in the first place. So it's quite horrifying, but that's what we're dealing with as well, right? While FDA towards small companies, we are actually living it. Our product is actually waiting to be FDA approved, and the laws and rules are very, very strict on what test that needs to be done on our side, which is completely understandable. But on bigger companies, it's a little different. So I actually encourage you to take a look at the documentary. It's horrifying, but it's actually talk a lot about what's happening. Just to talk a little bit about our product. And what we're bringing to the market and how we are actually facing the challenges. We are customizing gynecological prosthetics for women's health. So it's a problem that is called pelvic organ prolapse. It's the descent of the bladder, uterus, or rectum down the vaginal canal. Very uncomfortable condition, causes urinary and fecal incontinence, vaginal bulging sensation. So it's very horrible. And one of the surgeries that can be done to treat this problem is actually a transvaginal mesh that I just mentioned that has lots of complications. And it actually has been banned in 2019 by FDA. But before then, it was widely used, and everybody were actually using it and going through these unethical situations, while the bigger companies were actually getting profit out of this. And then also on that side, in terms of how these big companies face these innovations and actually work towards these innovations, in our daily lives, our vision as company is to grow the product and then sell it to bigger roles. So that's basically how even the mentors or everybody around companies push us to do. While bigger companies also, I think the ethical challenge there is to actually, when you look at the profit you're getting versus the ethical challenges that you have versus the patient need, which is on the line, right? So you sacrifice the need to actually get the profit that you're requiring. There are lots of small companies that have been acquired by bigger players just because they didn't want the competition to go. So basically bigger companies acquire these small companies but shelve the solution. So a small company worked for years and years to build a solution to make a better life, elevate the quality of life, but then the bigger company will acquire them but shelve the solution just not to have another competition for them. So that's a challenge that is basically we are facing in terms of decision making every day. Should we actually look into the solution? Should we actually bring the best solution that can be in the market? Or should we look at the profit to actually gain the return on investment for our investors? A company at our stage is living on investment. We are pre-revenue, right? And then what investors need from us is return on investment. I remember talking to one of the investors in our previous round and how they actually wanted us to go around FDA. And they were like, you know what, if there is a way you can get into the market without the FDA approval, we would like you to do that, because it's a faster to the market, it's better in return on investment. And we were shocked how open they were to actually even talk about this, and being able to kind of risk patients' lives just because they want that return on investment. And if I want to talk a little bit about how we're overcoming these challenges and decisions, I can say maybe so far we have been successful, but not really sure it could be something that happens to all the companies as they actually grow. They might, for surviving, they might be like needing to do some of these, actions and make these decisions, these hard decisions, just to be alive and survive. But just to give you an example, in terms of biocompatibility testing, we are providing an implant and it has to be biocompatible, even for small testing that we are doing, in vivo testings. It's very easy for companies to do this, and to build on your point as well in terms of consent. As long as patients consent to the test that you're actually performing on them, everything is actually fine, and you can actually proceed to the test that you want to do. But how aware they actually are when they are writing these consents of the exact details that you are testing on them, right? So companies can do this, and there's no problem with that. But in our case, for example, just to make sure that the implant that we're making, we could make it in our facility, but we are not an ISO certified facility just yet, right? We could do it. We could make sure that we are making it clean, etc. With I can tell you a couple of $100. It would cost us a couple of $100. But we are partnering with an outsourcing in the U.S. that has like certifications that is required, biocompatibility tests on that is required, but it increased our cost by at least $4,000. Now at this stage, we can afford it, and we will, but I'm not sure if all the companies can be doing that, and investors are not really supportive of that decision. That's I think the main challenge that small companies will have. So I guess just to overcome these challenges, it's very important, if you are an investor, if you're actually supporting investor community, it's very important to put the patient care, patient health, patient need over all the profits that is online. I'm not saying that we should forget about that, because that's business, that's life, that's economy. But it's very important to actually shed the light on that as well. And also I would say collaborative nature of looking at ethical challenges is very important as well. I'm coming from a technical background, I'm an engineer, and I usually look at the data privacy, like how we're handling data, and how I see as ethical challenge is that, how we're storing the data. Is it going to be hacked? Is the system going to be hacked if somebody will actually have access to the data? Well, as a physician from another perspective, one of my co-founders is a urogynecologist in Montreal, is a surgeon. He is very, ethics for him is that even we shouldn't pose a question that makes the patient uncomfortable. So the question you were asking, even about small things of lifestyle of the patient, is very important, and it really builds that ethical management of the company as well. So having that collaboration in the teams is very important, and we should encourage that as well. Just as a final, final note to actually finish this, is basically how we are, for example, the data and data management and everything that you mentioned as well. I think in terms of data science, how we are bringing digital innovation into the play, we should encourage how bigger and small companies understand not only the challenges, but also the underlying reasons. We can see right now, for example, with an advancement of something like GPT, so it's large language models, dialogues, you can actually ask them questions, they will answer you, like a computer that can do that. Using this can be very powerful, and at the same time very dangerous as well. So it's very important for our bigger collaborators, bigger hospitals that are in play to understand these underlying facts. Because if they don't understand it, they will just block it. And that's one of the challenges that innovation has, especially in Canada as well, because it's governmental. They're not trying to understand the underlying reasons of this, and they're not really open for disruptions. So they will block the innovation before it starts, while if they try to understand and put more support on understanding these underlying reasons, mitigating these risks would be easier for smaller companies as well. With that, I would like to close that. Thank you so much.
Great, thank you so much, Megan. And to conclude the kind of opening remarks, we're very grateful to have Dr. Lawrence Rosenberg. He brings a broad and rich perspective of healthcare across Montreal, both as a professor of surgery and medicine at McGill University, as well as the president and CEO of the Integrated Health and Social Services University Network for West Central Montreal. So, welcome.
Thank you very much, and thank you for the invitation for having me participate this morning. I wanted to give you a perspective from a rather long, maybe too long, a career here at McGill in medicine as a clinician scientist, as a healthcare innovator, and now as a healthcare administrator and manager in the system. What I thought I would do is go through very quickly about a dozen challenges that we face every day with respect to ethics and healthcare innovation. But before I do that, I just wanted to pick up on two of the things that the other panelists said, because they resonated with me in a certain way. And the first has to do with the notion of what is innovation, because everybody's focusing on innovation as synonymous with technology. It actually isn't. For me, innovation really is a response to an unmet need. And how you respond to that unmet need doesn't necessarily imply the need for a technology. So some of the most impactful innovations that I've been involved with throughout my career here at McGill were actually process innovations or business model innovations. They weren't technology innovations at all. And perhaps in the question period at the end, I can give one concrete example of that. The other thing I just wanted to mention, perhaps en passant, is that money isn't the issue. And I say that because if you look at the OECD data of all the healthcare spend in OECD countries, of which Canada is one, Canada spends more money on healthcare than any OECD country, and we have the worst results of them all. So putting more money into the system isn't going to solve that problem. We have fewer doctors per capita, fewer nurses per capita, fewer hospital beds per capita, although we're spending more money than anybody else. So think about that, I think, a little bit, perhaps for when you come up with questions at the end of the panel. So let me get to what I actually was going to talk about. In no particular order of importance, these are the things that we actually deal with daily, and Alan touched on a couple of them. Perhaps the most important is patient privacy and data security. Safeguarding patient information is absolutely fundamental and crucial, and maintaining strict privacy standards is absolutely essential, and I don't think anybody can debate that. In Quebec, we have an interesting situation as of last December, when the provincial government passed into law a piece of legislation which actually made your own personal medical information the property of the government. So it's not your personal medical information anymore, it's the government's medical information. Now, think about that for a minute. I remember sitting in a meeting at the ministry when the bill was being proposed, and of all the CEOs, healthcare CEOs on the meeting, and there were 34 of us, including a number of associate deputy ministers and the deputy minister, there were only two people who questioned why they were doing this and why our personal medical information should now become the government's information. Why 2 out of 45 people questioned this and the other 43 didn't is still astounds me to this day, because there's something inherently wrong with that notion, I think. The second point I wanted to mention, and Alan spoke to it, so I won't spend much time on it, is that of informed consent. And this is not just informed consent when you walk into the hospital and somebody's going to do something to you, including having blood drawn or receiving a blood transfusion, but as both my 2 panelists mentioned, the importance of data is becoming increasingly present day to day. And here again, there's the question of who actually owns the data. And when we talk about data, what are we actually referring to? Is it your lab results? Is it your genetic and genomic information? It isn't clear at all in the current legislation who owns that information. Although it is clear that whenever you're going to implicate a patient in anything, you need to figure out what the informed consent for that involvement should be. But it's still gray. The third thing is equitable access. So innovation should be accessible to all, regardless of socioeconomic status. And avoiding exacerbation of existing healthcare disparities is a real significant concern, which we really haven't figured out how to address yet. Quality and safety, obviously, entrepreneurs must uphold high standards of quality and safety in their products or services, as we've just heard. And this includes rigorous testing, monitoring, and continuous improvement. And the one thing I would point to here, which is probably going to sound a little bit antithetical or controversial to you, but the release of the COVID-19 vaccines over the last several years has been extremely unusual with respect to the lack of testing and the lack of transparency with respect to the complications that these vaccines and the subsequent boosters have caused. Most of you probably don't follow the periodic reports that come out from the CDC, and many of you probably don't have access to emails that are flying back and forth between various officials of the CDC and various governments. I've seen some of them. It's actually quite alarming with respect to what was known by Pfizer and Moderna with respect to complications of the vaccine, which were never made public. I think this is a very serious problem with respect to quality and safety and transparency and integrity. The next point I'll mention very briefly is regulatory compliance, which both my panelists mentioned, which is extremely important, so I won't touch on that any further, other than to say, in Canada with Health Canada, which is a fairly good, robust regulatory authority, regulatory authorities can become rather bureaucratic. And they end up existing for the sake of the regulation without thinking about why they exist in the first place, which is to protect the public and to allow something to be introduced to the public in a timely fashion. So there's a disconnect there that I think somebody needs to address. Conflicts of interest, again mentioned by both my panelists, I won't dwell on that. Resource allocation. So with limited healthcare resources, entrepreneurs must consider how their innovations impact the allocation of resources, particularly in situations like a pandemic. And I can give you 2 very good concrete examples. At the beginning of the pandemic here in Quebec, we were the first healthcare institution to actually set up a supply chain for PPEs, gloves, masks, gowns, visors, whatever. And that's an interesting story in itself, which I won't dwell on now unless we get into it afterwards. But all this to say is, because we set up our supply chain 4 to 6 weeks before the rest of the country, we were able to get access to well-priced, high-quality materials. Once the government, provincial government, and other provincial governments declared their public health care emergency, everybody was scrambling to set up supply chains for the PPEs, and the quality of the material that ended up coming into the country was actually quite poor in many places, and the costs were hyperinflated. Something wrong with that as well. I've touched on the issue of genetic and personalized medicine, so obviously privacy, consent, and the potential for discrimination are key concerns in the realm of genetic information and personalized treatments. And the one thing I would point out here, aside from ownership issues of the data, is the unintended consequences for people of having their genetic or genomic data made known with respect to their ability to subsequently get insurance coverage. So you may have a genetic risk of developing a certain illness at some point, maybe 10 years from now, 20 years from now, maybe never. If an insurance company were to find out about your genetic risk or pseudo-risk, would you still be able to get insurance coverage? It's not clear. And nobody's addressing this at the moment. Ethical marketing and advertising, I think everybody's touched on. I won't dwell on that. Alan talked about research ethics. That's an obvious one, which I won't dwell on. I'll just close by talking about two global health considerations. One is entrepreneurs working in healthcare must consider the global impact of their innovations, especially in terms of access and affordability in different regions. This is absolutely critical. And the last thing I'll touch on, which also has global health implications and involves our governments, primarily our provincial governments, but indirectly our federal government. We heard a little bit at the beginning from our first panelist about the challenge of manpower planning and shortage of manpower. And the solutions that most of our provinces have gone to is to go to other countries, third world countries, depopulate them, and bring their healthcare professionals into Canada. To me, there's something inherently ethically wrong about that. And I can give you two concrete examples, which I'm well aware of. Any day now, they're expecting 700 nurses to arrive in Newfoundland from India. And there's about 540 nurses that are expected to arrive any day now in Nova Scotia. I don't know what the impact of this is going to be in India, which is a country that is rather challenged when it comes to the provision of healthcare. But again, nobody is discussing this issue. So I think I'll close with that.
Thank you so much. With that, I think we'd like to open up to questions from the audience. So we have a microphone or two, but feel free to raise your hand and fire away.
For the recording, if possible.
Okay. The microphone's there, or I can bring this one down. If you want to sit, if you want to sit.
Yes. Okay, so I am addressing the question mainly to the lady here on the panel. You mentioned that the FDA and Health Canada does not do enough testing before a product is put on the market. Yeah. How come that is the case? Why are they not doing their job, in other words?
Yeah, so thank you for the question. So basically it's the disparity between the small companies versus the big ones. They actually have very restrictive laws and rules for the test that needs to be done. And I guess they actually adhere to them very, very well. I guess the problem is mostly for the bigger companies that has been there for a long time and has been showing more successful products. But maybe that's why for a couple of examples, there are not sufficient testings that needs for them to get into the market. And I think I cannot say the main reason there, but with different examples, we've seen the agent that is actually specified for that particular case. Sometimes that's the issue. Sometimes the predicate because when you're doing like FDA, if you want to submit, there are like 510K routes that you can take based on the predicate devices that are similar to your products, and then if you can show sufficient similarity between your the products and them, then you get the fast track to get into the market. Or some of the products, such as for example COVID vaccine, that has a fast track that needs to get into the market without the sufficient testing that is behind. So I think there's not one reason for all of this to happen at the same time, but what we've seen is that for bigger companies that have shown better results usually, and on some of the products there has been their products that got into the market without the sufficient testing that needed to be done beforehand. Especially in the women case, it has been shown that most of the test has been happen on male counterparts, even on the animal testing. And what happens is that they do that because the hormonal cycle is more controllable in compared to women, and they want to get into the market faster, so they don't take the time to do this, and the priority is not that at all. So you might pass some testings on some of the people, but it's not representative of the whole population. But apparently that's not also one of the priorities as well, so I would say that that might be another reason.
Yeah. I'll add a little bit if you like.
For sure.
And I think I would say that there's lots of things that I would agree with. And the other thing that I would like to add is that there is a piece of this which is not just the upfront approval, which has got some challenges. There's also the post-evaluation surveillance. Exactly. And I think that's where, as a society and perhaps as a regulatory regime, we might start to see some opportunities. You know, there are times there is a good reason to rush something through because if there's an unmet need and a product that has a transformative benefit, but we may not have all the information at that time. And right now, once it gets that approval, it's through. And there may be times, just like in the mesh example, where short-term studies showed benefit, showed little risk. It was the longer-term follow-up where we started seeing the problems. And the other thing that could happen is there could be a very strong operator effect, where later on it's getting put into settings where perhaps people aren't trained properly, or where they're using the device or the technology in a way that it wasn't set up for or approved. And so for monitoring post-approval, I think is actually the more important piece. And again, I could talk about why that exists like that, but it does, if we changed it to be perhaps a lower threshold to get through the first door, but then ongoing thresholds later on in the life cycle of an innovation, I think we'd probably be a little bit better prepared to move it forward.
Absolutely.
Maybe just a question to my colleagues here. I am more familiar with the food than with the healthcare, but the question that I'm asking, could it be that it's one thing to have regulation, but it's another thing to have resources for reinforcing them and test the compliance? Can it be in that context?
100%. And you know, 100% true on that front, because I'll say that, you know, they talk about healthcare being strongly regulated, but there, you know, at a professional level there is regulation that's, but in terms of the actual oversight and the ability for accreditation bodies or review bodies to enforce action, especially in a country where there's a single provider, is almost impossible. And especially one where it's so tied to the political process. And so I think enforcement of audits, of enforcement of regulatory actions is something that we need to take a hard look at.
Good. Other questions?
Points are very well taken, and thank you for sharing them with us. Just a few considerations that Health Canada does have in place NOCC for some of the drugs that meet a very high unmet need, specifically in the cancer space where we don't have any other options. Conditional approvals are based on the fact that the government does collect or requires manufacturers to collect data on a drug to see how a drug is doing, and then may or may not pull out drug from the market if the drug does not show any benefit to society. So that's one. And the other consideration is that there are risk management programs in place as well that are part of the product monograph. I think what's very interesting to see is the shift right now that is happening with the FDA, where the FDA is mandating that we have representation from different races and ethnicities in the trials, and will no longer approve a unified demographic, which is like hooray. A very big coup for society at large. So those were just my comments to share with the panel.
And I would just to say, like, those are great examples. The problem is they don't necessarily apply to the digital health space as well. And I don't think this is necessarily just on the regulator. I think this also falls on the providers and the users of the technologies. We're buying the technologies, we're using them. We're not necessarily reporting back when problems are occurring. And that's to your point. I think that and to me there's a capacity issue. It may be a financial capacity, but it also is a knowledge and understanding of some of the impacts of some of these things. So I don't want to put this all on the regulator to change it. It also has to be the industry. And I also probably think there's probably the new technology companies have to change as well. I mean, we all probably have part of this.
Yes, this is great fun.
You haven't changed.
I'm a physician, but I am not an expert in bioethics. But I have been continuously struck, and we've had informal conversations, with the fact that you're all dealing with essentially ethical dilemmas, the end result of a series of examining tensions in our system. I'm old, I've been around a long time. I've lived through the growth of bioethics in medicine. And our growth was reasonably solid because we started with general principles. And I haven't heard a single principle from any of you. Lawrence came closest. If you, I haven't done it for years, but if you Google bioethics, you will find out that there are 4 pillars of bioethics: autonomy, non-malfeasance, beneficence, and justice, with apologies to John Rawls. And anybody in medicine who's dealing with ethical issues has to either accept or replace those general principles with others. And I would wonder why you are not looking for general principles that can assist in addressing dilemmas that face us every day. And you know, some of it's going to be in the law. I mean, conflicts of interest should be easy to codify, but nobody's done it. Insider trading is it's part of your issues and so forth. And my final comment, which is linked to the first, is that our entire system, including our healthcare system, depends on us accepting the parameters of a social contract. And the nature of our healthcare system is actually determined by our social contract. And the differences between us and the United States are predetermined because we've got a different macro social contract than does the United States. And this social contract depends on trust. And what you're talking about impinges on trust, and not one of you mentioned the word. So those are my 2 sort of directions that I think I would suggest you might take. By the way, the general principles are going to be more difficult for you because you're essentially dealing with 2 paradigms whose value systems are hard to correlate. The healthcare, the care of the ill and the fiduciary duty to shareholders. And those are really tough. But I think you should be able, you might even have to have a different set of principles for different parameters of business. But I think that's where you should go.
I missed out. I haven't argued with Dick for many years, and I completely agree with what you are saying. But I will add, though, that general principles are important so that you understand mechanistically what is happening. But when we talk about impact, you need to impact human beings. And that is why when we were talking about looking a bit at heterogeneity in those basic mechanisms, it's also extremely important.
Should we rebut?
Yeah.
No, I think your comments are right on, and I would say that we're trying to outline the problem. I think I did say trust, though, by the way. but I would just come back to this accepting the parameters of the social contract. For me, I think not solving this problem using principles is the we're putting our whole social system at risk in many ways. Like, and I don't say that lightly. I say that with if our society, if our people, our population believes we're there to look after them, and yet we're not looking after them. And they come at a time of where they're very, very vulnerable. There's a huge impact to their trust in government and their trust in our systems of governance. And we have to, this is not a sort of minor issue. This is, I think, fundamental. And that's why I think having these conversations is so important. So I would agree that framing it that way is important.
Just think of the lack of trust that the medical profession has in its own healthcare system. Now,
exactly.
Throughout the world.
Yeah.
But I would like to comment on the social contract. I was talking about this convergence by design before. We are talking about the whole person in a whole of society. So this notion of thinking that the person is just the beneficiary is also, we are part of the contract, social contract of the society where we live. So I think that that is a mindset that we need to change in some way. The patient is not just this patient waiting for the doctor. The patient is also the grandmother, the patient is also the consumer, the investor, and so on. And the social contract involves all of the above.
First of all, I want to thank Dr. Cruz for the reality check. But I had a very specific question about the greater success of large organizations in getting their innovations approved, whether it be by FDA, CDC, and government formularies. What role does lobbying play in that?
That's a good one.
I'm not that close. I mean, I'm not a regulator. There's a lot of, when you're a big company, you can do the studies. You can motivate the field and get them engaged to help you with the studies. You can figure out the risks. But you also have more influence at the government level. My sense is that the people who are involved in the regulatory tasks are very pure. And pure in the sense that they've got a framework for decision making in which they apply in a consistent fashion without influence without influence from outside forces, unbiased. But But how it plays out in terms of the data that's presented and the acceptability of that data, you know, I think it's always open to challenge.
I think we are a bit naive. Whoever we are human beings. And thinking that the context does not influence human decision-making or machine decision-making prevent us from doing better than we are doing now.
Yeah, I agree, but I'm not sure that the size of the company is what produces the bias.
No, that I agree.
Yeah, and I think the size of the company may influence the marketing and the uptake post, and also the pressure to get it, like the testing that gets required to get in front of them. But in terms of the actual decision, I don't think it. Anyway, that's just. Also, the big companies find the little companies.
Hi. My question is for the panel here. Dr. Lawrence mentioned that there are a lot of issues with respect to healthcare professionals, and he mentioned that a lot of nurses are going to come from India to Newfoundland as well as from other countries. So is there a notion among people that this is the only available? Hello? Yeah. Is this a notion where this is the only available solution, or is there something else that we can explore in terms of this problem? Thank
you. It's a complex issue because importing allied healthcare professionals from another country is a short-term fix, really putting a Band-Aid on somebody that's hemorrhaging and needs more than just the Band-Aid. The problem is it takes several years to train a competent healthcare professional. So for example, to train a medical specialist, from the time they enter medical school to the time they're ready to go into practice could be 12 years at a minimum. Increasingly, the nursing requirement for practice is not the typical RN certificate. It's at least a bachelor's degree, if not a master's degree. So again, that adds an extra 2 to 5 years to the training of nurses. I think what may help us is that other allied healthcare professionals are beginning to expand the scope of their practice, which will allow individuals to do more than they did even 5 years ago. And so, for example, things that specialty physicians were doing exclusively can be done by family physicians, and things that family physicians used to do exclusively can be done by advanced practice nurses, and things that advanced practice nurses used to do exclusively can be done by less skilled allied healthcare practitioners, including pharmacists. But the two new elements to this calculus, one is AI, undoubtedly. And everybody is going to have access to AI sooner than you think. Generative AI is going to make a profound change in how healthcare is provided, probably within the next 24 months. Both Alan and I were at a meeting in Boston 2 or 3 weeks ago where we saw the world's first demo of an AI, generative AI chatbot, I guess is what it was, that completely replaced the presence of a professional human in the interaction with a patient in a way that I think everybody was completely blown away. And that's just the beginning. And this is a technology that will hit the market, according to the company's CEO, by the end of this calendar year. So I think that will help with the manpower shortage. The other, which I think is underrated and scares people, honestly, is that we as individuals, as citizens, have to take more responsibility for our own health. And I'm emphasizing health as opposed to health care. Because if we're going to move upstream in terms of rationalization of resources and costs, we do need to get away from the notion of health care and move to health and wellness. And that's something that I think industry is beginning to recognize, governments are beginning to recognize, and I think there's a whole world there that needs to evolve as quickly as possible.
Yeah, if I may, what you just mentioned made me think of one ethical challenge that I forgot to mention. I was saying that I work in food, but I also work in autonomous vehicle and so on. So that brought me to look at the ethics consideration where your system is this mixture of machine, data, algorithm, and human. And this is a whole next generation of thinking of ethics. I think I shared with the panelists this morning someone who was sending me just a report that came out from Stanford. And I'm very much kind of let's work and use as much of the human and the machine capacity as we can. But this report was talking about ChatGPT responding to patients' question with manifestation of just preserving the good old, like different things for gender or ethnicity and so on. So it's just that we need to be absolutely forward-looking, but very pragmatic in terms of, from an ethics perspective, our object is not just the professional, not even the system in the professional, it's also the way we create this cyber architecture and so on. And that's something that we have not mentioned so far that is important.
You have to realize that when you talk about healthcare, everybody is immediately fixated on hospitals. 85% of the population will never come into a hospital. So for some reason, we're fixated on the 15% that do. We need to redress that. And the way to redress that is to focus more on health than healthcare. And I can tell you that probably everybody in this room who's visited an emergency room or knows somebody who's visited an emergency room, the number one complaint is I have to wait too long because the place was too crowded, without thinking that you're one of the people there contributing to the crowding. 60% of patients who sit in an emergency room or who go to an emergency room do not need to be in an emergency room. And most of those patients, and I'm not exaggerating, most of those patients, if they had access to what's coming in terms of generative AI, would be able to interact at home with their own healthcare manager and get the information and the advice that they need. And that's not science fiction. I'm convinced that this will be the norm within the next 24 months.
I'm just going to go back to the comment about India. Or one of the benefits of working in innovation as a global community is that you have different patterns of things that get in the way, and you start to solve things at one setting and versus another. And this is speaking to the issue of professionals. I think to a certain extent professionals are protecting their turf in a lot of places, and their turf is often, it comes with financial benefit and also status. In settings where the finances are not available, there is more opportunity to do experimentation. Perhaps, and I think like I saw an example of at the same conference, we saw a machine that would read X-rays, read MRIs, read CTs. The barrier to that adoption in Canada is being radiologists who don't want machines to read their MRIs and take away their income. The country where that product got developed, the radiologists were paid a salary, and it didn't matter how much they were reading or not. Mm-hmm. And there, the technology advanced very, very quickly and has been adopted, and is coming to North America. So there are some issues around professionals blocking the areas of success, and we've got to keep our eyes open to that as something that's good.
If I may make a comment, and coming back to what you just said, Dr. Goldberg, also about the fact that its hospital is 15%. Having worked for 30 years at the convergence of health and economics, and between the hospital, what you call the allied professional, and the community in the real world, the budget, even if you say that the budget is not important, it is extremely important. The bulk of the healthcare costs still go to hospital. How do we change this?
Okay, I'll give you one concrete example of how to change it, and it comes from the Israeli healthcare system. And I was blown away when I sat with their largest HMO a few years ago to try to understand how they fund the system. So Israel has a population about the same size as Quebec. The country's divided into 4 HMOs. The largest HMO, called Clalit, is actually the second largest HMO in the world after Kaiser Permanente. Clalit is divided, to your point, into a hospital division and a community division. You know who controls the budget of the hospital division?
The community?
The community division. But more than that, if the community division is not happy with the quality of the service they're getting from their own hospitals, or if they're not happy with the cost of their own hospitals, they're allowed to go negotiate with another HMO's hospitals to get better cost, better quality. So I think that's the answer. And the problem in Canada is, what drives that is competition. And I think everybody would agree that competition drives innovation. We have no competition in Canada, and that's a fundamental problem.
First of all, I want to thank you for all your insights. It's really so much at that table. You have so much wealth of information. Going back to previous conversation, we have healthcare assessment technology bodies, and we haven't heard much about these. Are they a good resource? Do they get enough funding to be a better resource? If any of you could comment on that.
Go ahead. You want to go ahead?
It depends what you refer to as healthcare oversight or regulatory bodies.
Health technology assessment.
Yeah, health technology assessment. It comes back to what I said at the beginning, the focus on technology. And one of the problems that we have, and I'm sure everybody has, is that when we get approached by companies or entrepreneurs, they approach us with their technology. We're not looking for technologies. We're looking how to solve unmet need. But they don't get that. If they understood what the unmet needs were, then they would focus the development of technologies on where the need is, and not on the fact that they've got some brilliant physicist or scientist or engineer who's come up with the next great toaster. So that's a problem. But the real issue is who's evaluating the outcomes of health care, not necessarily technology assessment. Because more important than the technology assessment is the assessment of the outcomes of the care that's being provided, regardless of the technology that's being used. And therein is another problem in the Canadian healthcare system, because every single Ministry of Health is focused on volume of activity and not on quality of the outcome or the value of the care provided. So to Dr. Cruz's point with respect to the social contract, it's flawed. It needs to be rewritten, because if the only thing the ministers of health care about is how many operations we're doing, even though you may be killing everybody you operate on, they don't care because they don't ask. It's not one of their indicators that they track. I mean, this is a serious fundamental problem of the system.
So I would answer
By the way,
yeah.
The social contract is being renegotiated every day.
Yeah. Okay.
In small units and so forth.
Okay. I'll answer your question to say we need more TAUs. we need more technology assessment, and we need better decision making, and we need better incentives to drive us. I don't think we don't take advantage of technology assessment programs to the extent we could. I hear when I talk to technology assessment, I've done it all my career, is people don't want to hear the answer and they won't acknowledge it. They either want to go ahead with it or they're going to say no anyway, depending on their bias. And so, to Lawrence's point, we need to hold our leaders accountable for getting the outcomes, and they will only get the better outcomes if they use the best technology. And then technology you can use fairly broadly, like in terms of processes and people. So I wouldn't discount the technology assessment teams and people on this front.
But isn't it also that maybe the innovator starts in the wrong place?
Yes.
They come up with an idea instead of finding what the unmet need is and then going backward.
Correct. Well, but I find the innovators are always coming in. Like most of the innovators I talk to, like have real opportunities to solve real problems, and our frameworks don't fit very well for them because but that's not like that to me is not necessarily the problem of the TAU. That's at a higher level. So. Sorry. Yeah. Go ahead.
Just from an ethical standpoint, I think that part of the problem is also because there doesn't seem to be a common language around what is ethics. I'm saying this because I just graduated with a bioethics master's, and I'm baffled by it goes in all directions. There's so many frameworks, and as long as there doesn't seem to be an overarching language, it'll be hard, I think, to corner the many issues.
I would like to make 2 or 3 points in this conversation. One is that technology assessment is the good old stage-gazed assessment where we assume that technology is out there and we get away to the market. And I kind of agree with what Lawrence said, that may not be the need. Just work better with your community or whatever. So that's an important point, that if we continue this model only, then I was yesterday participating on a panel, on a webinar panel where our own Rémi Quirion, who is the longest standing scientist officer worldwide, and with others was talking about the innovation strategy, and it's all about technology. Somewhere you bring the social, but it's not at all embedded into our culture, our social contract, and our reality, in the sense that the linear pipeline is passé in many, many domains where you work and you get responsible innovation, including innovation that advance a bit, but still, as long as we look at pipeline by pipeline, discovery by discovery, we don't bring what I call whole of society solution, because everyone bring its expertise and so on. So the system needs to be tweaked in significant way, step by step, boiling the ocean one drop at a time, but system level thinking is very, very important.
Just to add a little bit on that as well, and to your point as well, to have actually a common language, that's something that is like VC, it's missing as well. That's why we're actually bringing people who have medical background plus people who are actually working in technology. We need that translation between these two for it to excel as well. For most of the urogynecologists or physicians that we actually interview, we see that they see this AI as a black box that they cannot really trust, and they don't want them. It's not necessarily, like it absolutely is regarding resources and the financials that they're getting, but also the unknown nature of this, of like how exactly it works, how much I can trust on this results. So that translation is very important. important for data scientists to actually bring interpretability to their models, for physicians to be understanding that so they can rely on it. That's very important as well. And then finding that common language between technology and what actually that company brings to the table to serve that unmet need that Dr. Lawrence mentioned.
Thank you. Thanks to all of you for your comments. I have to say my thoughts are firing, my neurons are firing in all sorts of different directions with everything you've brought up. But going back to a couple things, social contracts, considering the population and the fact that our healthcare system is absolutely burdened, more and more patients are left to their own devices to take care of themselves. We're no longer in a system with, Tommy Douglas, acute care. We've moved more to chronic care, so more and more our Canadian population is taking care of themselves more often than not. So thinking about the notion of the fact that we should be leading our population in general to think more about preventative care, how do we manage wellness, etc. I also wonder about if we're leaving the opportunity of going back to basics with respect to innovation, and by that I mean we have so much technology that is at our disposal, but when I think about the literacy problems, when I think about health literacy, and then following very closely on its heels, electronic or digital health literacy challenges and issues, what are we doing in order to bring our populations into line in order to ensure that the technological assets that we're developing are something that can be really taken care of?
Do you have an idea?
I have plenty of ideas.
Fire those neurons.
Yeah. I'd love to discuss them with you if needed, but I do think we need to think about that.
Them without talking to your target. That's the key point. We develop technology and we think that the world should use them. It doesn't happen. It has to be all those projects that I was talking with many collaboration with the CE Centre was. It is working with the real people before building the technology. And that's really one of the key next steps that has to happen.
I think as well, it really needs to be systemic. You know, if we were to think a little bit more preventatively by ingraining, I call it planned patienthood, but starting from primary care to primary grade 1 through grade 12, and then in the healthcare system, medical school, we should be, I think, really harnessing every individual with the opportunity to empower themselves to understand how to work their way through the healthcare system and how to stay out of it, if at all possible.
I like it. Planned patienthood. Unfortunately, we're all going to have an illness at some point, like all of us. And
really?
Unfortunately, I said. Maybe that's the goal of today, then, is to not have planned patienthood. We're not all parents. Not everyone wants to be a parent, but planning is always good. So I like it.
Great, thank you so much. And I know there's many more questions in the audience, but this is just the first panel of the day, so we have the whole rest of the day to unpack and bring out some of these. Thank you so much again to the distinguished panel for sharing your wisdom with us. And thank you all. We'll wrap it up and head to lunch, I believe.